would like to invite our next session moderator, Dr. Govind Babu sir. He's a senior consultant medical oncologist from Bangalore, so it doesn't require any definite introduction. And our examiners are Dr. Navneet Singh sir. अच्छा सर के एग्जामिनर नंदिनी डॉक्टर नंदिनी मेनन, नवनीत सिंह सर, डॉक्टर नंदिनी मेनन, डॉक्टर भावेश कोलाड़ी. And to present the case, Dr. Sayakti.
Hosts of voice or ptosis, and there was also no history of jaundice, headache, vomiting, and seizures. So coming to the past history, there was no history of similar illness in the past. There was no history of TB, bronchial asthma, or ischemic heart disease. There history of no any major past surgeries, and she is known hypertensive since last 10 years, and she is on telmisartan. Coming to the personal history, she is married, and there is no evidence of any bowel bladder disturbances, no history of addiction, and she had completed 3 doses of COVID vaccination. Coming to the family history, there was no history of any similar illness in the family, no history of TB, tuberculosis in family members, and there is also no history of malignancy in the family. So, coming to the treatment history, the patient has received antibiotics and cough suppressants. After which there was a mild improvement in the cough, but the symptoms recurred after stopping cough suppressants. So, summary: it's a 40-year-old female, non-hypertensive, presented with complex of chronic cough, which was gradual in onset and aggravated since last 15 days. And it was associated with sputum was occasionally with mixed with streaks of blood, and there was no, and also associated with loss of appetite and weight loss of about 5 kg in last 1 month. So coming to the differential diagnosis, it may be pulmonary tuberculosis or carcinoma of the lung. Next, coming to the
So, I mean, the symptoms are largely similar to what I think the previous thing, right? So you have cough, some hemopsis, vague chest pain, and anorexia or weight loss, right? So apart from pulmonary tuberculosis and lung cancer, can you think of anything else you or anybody? They can even mimic these two radiologically. No. Not really. So, certain chronic fungal infections and pulmonary vasculitis, especially Kanakasetty, they can clinically and radiologically mimic tuberculosis and lung cancer.
Just go back on your slides. In the past history or history, yeah. You've written known hypertensive.
Yes, sir.
So is there something called unknown hypertensive? So I think proper English. Yes. Known to have hypertension or is on treatment for hypertension. Okay?
Yes, sir.
I think you should make those corrections.
Just wanted to add that since she's a female, so what sir said was correct. You have to think about connective tissue disorders also.
So you also give a history of antibiotics being given.
Yes, sir.
Would you like to tell us how, in the time frame, when did she get it, when did she stop it? And you think that has any relevance to the further treatment you could think of giving this patient?
So she was she consulted a local physician and she had given antibiotics for, and after that there was no symptoms.
So I'm talking about the time duration of getting these antibiotics. And why do you think it has any bearing on your future treatment that you might plan? I'll give you a hint, Dr. Navneet, stop. No? Anybody? Response to immunotherapy plus the use of antibiotics. No? No? Yes. There is data now to say 1 month before, during immunotherapy, better to avoid antibiotics because your responses are blunted?
Both PPIs and for PPIs and antibiotic usage during immune checkpoint inhibitor therapy, they are known to adversely affect responses. It doesn't mean that if it's indicated you don't give it, but it's just an association which has been shown to be there. That's all. And that may be the mechanism, the change in the microbial flora, which can in turn affect response.
So coming to the general examination, the patient is conscious, coherent and oriented. The height is 150 centimeter, weight is 3 kilo and BSA is 1.65 per meter square. Temperature is 90 degree Fahrenheit. Pulse was 96 per minute, which is regular rhythm, normal volume and normal character, or peripheral pulses are felt. BP is 120/70 millimeter of mercury in the right upper limb in supine position. Respiration rate is 24 per minute regular. And SpO2 was around 97% at room air. There was no any pallor, icterus, special edema or clubbing. There was no supraorbital lymph nodes are palpable and no bony tenderness was elicited. So coming to the systemic examination, so in the respiratory system, the upper respiratory tract, the throat and nasal cavity was normal. On inspection, the chest was asymmetrical. The respiratory movements are decreased on the right side. Trachea is in midline. There is no signs of any volume loss, that is shoulder drooping or rib clouding. There is no dilated veins, sinuses or visible pulsation anywhere over the chest wall. And also there was no usage of any accessory muscles. On palpation, the inspiratory findings were confirmed. On percussion, there was a dull note over the right second to fourth intercostal space. And on auscultation, there was also a decreased ER entry on the right to second fourth intercostal space. And all the others have vesicular breath sound. So cardiovascular examination, the S1S2 was normal and there was no murmur present. On abdominal examination, there was no organomegaly felt. And on CNS examination, the higher mental functions were normal and there was also no motor or sensory deficits. So summary. So it's a 48-year-old female with non-hypertensive complaint of chronic cough, which was gradual in onset and aggravated since last last 15 days. We were associated with sputum. We were actually mixed with streaks of blood, and also it was associated with loss of appetite and additional weight loss of about 5 kg since last 1 month. On general examination was normal, but examination of the respiratory system reveals dull percussion note with decreased breath sounds over the right second to fourth intercostal space. So coming to the differential diagnosis is remain the same. Is pulmonary tuberculosis the first, and my second will be the carcinoma of the lung.
Just a correction, I think that was the same description in the previous case also. You really don't use the term decreased air entry. That is only used for an intubated patient to check if the endotracheal tube is in the right position or not. For a person who is breathing normally, you will just describe the intensity of breath sound. So you can say intensity of breath sound is reduced here or in whatever area it is.
So come.
Auscultate in the intercostal space. You specifically said second and fourth intercostal space. How did you auscultate in the intercostal space?
It's on the level from this second to fourth. So level is found that is a decrease.
It's not intercostal space, no.
Yes.
You should describe that region as such.
So coming to the investigation, routine labs were done at the CBC biochemistry, which include the RFT, ALFT, symptomate and calcium, and also the vital markers. Then next will be the radiological chest X-ray, followed by the CCT of thorax, and also the biopsy for pathological diagnosis. So on
Yes. She had hemopsis, right? Yes. So that is the first test, right? I mean, this could be tuberculosis, same as the previous case.
Yes,
So you can not just do acid-fast bacilli, you can also do the gene expert or the CBNAT, which the nucleic amplification tests these days.
So coming to the investigation, the hemoglobin was 12.7 gram per DL, TLC was 7.8, platelet was 393. All the other biochemical parameters were within normal limit. in CCT thorax, there was a necrotizing constellation in the right upper lobe. GGO with smooth septal thickening was also seen in the right lung apex. Multiple small rounded cavitary pulmonary nodules which showing surrounding GGO are seen in the rest of the bilateral lungs. So lung biopsy has been taken from the right upper lobe and it was characteristic of adenocarcinoma. EGFR, ALK, loss were all negative, and period 1, the tumor proportion score was 20%.
So before you did the lung biopsy and you had the imaging, I assume you don't have the films, right?
Yes, the films. I have seen. Next please.
You should show that. You should show that first. Yeah. So before you have done the diagnostic procedure, so you have the imaging, right? So why don't you show us the imaging? You have the CT scan films.
Yes. So there is a mask-like constellation seen in the right.
This is a PET scan, right?
It's a PET scan, sir.
You were showing the CT findings, right? So do you have images of those?
No, we have no finding of CT scan.
You don't have that. And so let's assume that, just go back to that step. Back. Yeah. So if you had these findings and we haven't seen these CT films, then amongst all the differential diagnosis, which one would be the first possibility?
The tuberculosis? No.
No.
It may be the carcinoma lung, maybe the family.
No.
It is multiple lung nodules.
Vasculitis. You have necrotizing consolidation and you have multiple small cavitating nodules, right? So if you do not have a biopsy, and obviously a lot of the interpretation would develop upon seeing the CT films, but just based on this report, then a vasculitic process would become more likely.
So after the biopsy came, the report came to adenosine, the PET-CT was done. So there was FDG, a bit mass-like constellation involving the right upper lobe. Size is about 30 into 7.6 centimeter, and the SV was 16.74, with few areas of constellation also seen in the right lung in the middle lobe with patchy increased FDG uptake. There was multiple sub-centimeter capillary lesions scattered in both lungs with surrounding groundless haziness. There was no significant pleural or pericardial effusion. FDG avid nodes are seen in the right upper and the lower parietal and subcranial region, and also there was a right sub-centimeter right level 4 lymph node where SV was 3.35 centimeter, and was no evidence of any metabolically active disease elsewhere. MRI brain was done. There was no evidence of any neuroparenchymal mets.
So what additional information did you get from the PET scan? So before, I mean, you had the CT scan and you had the biopsy which showed lung adenocarcinoma. So what was the stage then?
It was stage, initially it was stage 4. Did you read it?
Correct.
Correct.
And so if you have done the PET scan, so how does it change your plan or management?
What additional information are you getting in the PET scan?
Any other sites of mets apart from the in the thorax, maybe adrenal or in the bones or.
Okay, so accurate staging is fine. I mean, it was M1A disease based upon the CT scan.
Yes, sir.
You could have got M1B or M1C disease,
Yes, sir.
right? But then how would that have changed management?
It will not change.
So then why order a investigation if it is not going to change your management? It's fine. I mean, it is recommended as part of routine workup, accurate staging. It is all fine. But in real life, and suppose the patient has to pay for that, or there is like a 8-week waiting for a PET scan. So if it is not going to change your management, you may or you may not do it, right?
Yes, sir.
Maybe just
Do a
I
PET
think
CT or will you do a CT scan if you have the option? What would you ideally?
Ideally, we should do an average PET scan because it will just.
So this patient came with a CT scan?
Yes, sir.
Okay. So in your sequencing, would you do a PET scan first and then a biopsy, or a biopsy and then a PET scan?
We will do a biopsy and then we will do a PET scan.
So what is your argument for both?
So if the biopsy came out to be something non-malignancy, then we will avoid doing the PET scan and the management will be a different line. And if it's come to be malignancies, then we can able to stage the disease
But you already said, earlier, patient comes to you directly, you will not do a CT scan, but you will do a PET CT first, right?
No, sir. First, we have to do the NCT thorax. If the patient comes with any respiratory symptoms, and after the biopsy come out to be some malignancies, then we can do a.
They'll come to you, and most of the times your strong suspicion is malignancy.
Yes, sir.
You can avoid 2 different scans. At least that's what, practically speaking.
So if if the patient has come without a CT scan, what CT scan can you do and you don't know the diagnosis yet? What you can order, you are going to order an investigation, right? What will you write for the CT scan for the radiologist to do, and you can get answers to a lot of things.
NCT thorax and upper abdomen.
So why NCCT? Let's assume patient has normal renal functions, no contraindications to contrast. Why NCCT? So what was being said for the previous case, a contrast enhanced CT scan of the thorax, including at least the liver and adrenals, and with the current CT scan machines available, an HRCT can be done simultaneously if required. So if you don't know what is the diagnosis and you're ordering a scan for the first time, it could be a CCT thorax, including upper abdomen or whole abdomen if you want, and you can do the HRCT in the same setting.
Maybe I think just one additional thing what PET scan will tell is a bone uptake. That will be additional information beyond CT scan thorax.
So if bone is your, if you have suspicion of bony metastasis and you already have a CT thorax and abdomen, can you do something else and not do a PET scan?
Bone scan can be done.
Sure. And typically the cost of a bone scan is much lesser than a PET scan.
So the diagnosis is a carcinoma lung. The stage is T4N2 M1A, and M1 is due to the involvement of the contractile lung, and adenosis, which is stage 4 disease. So the plan of the treatment would be give pemetrexed plus carboplatin plus minus pembrolizumab, depending upon the patient's affordness.
Do you want to biopsy the opposite lung lesion? And if so, why? If not, why?
Because mostly
in this case we can do actually as discussed with the sir, because the characteristic nodules are like small cavities, otherwise we don't need to.
You already have the biopsy, right? Just showing your adenocarcinoma.
Otherwise we don't need to repeat the biopsy in the contralateral lung.
I will say I want to do. So how can you support my thinking? There's a recent case report, because these are just case reports, of looking at mutations in 2 different lesions, 2 opposite lungs in the same lung, 2 lesions, and they found different gene expressions. And normally you don't do, but if you want to do, you can explain this.
Suppose you did not have this 7 centimeter or whatever size, all you had was multiple nodules, and one of them being apparently the largest, but you don't have this size. Would it change your stage? Would it change your T stage?
the stage will
Would it change your T stage?
Yes, sir. Yes, sir.
You right now you have a report of whatever 8 by 7 centimeter, whatever. Suppose it was not so big. It is perhaps less than 5 centimeters or 4 centimeters, whatever. And the same description, would it change your T stage?
If there is more than the knowledge of everything is more than
Yes,
one.
sir.
How?
So,
How would it change your T stage?
we take for the T, we take the size more than 7 centimeter, but if less than that and
It will, in this case, it will not change. Remember, the highest T descriptor applies. You already have nodules in the non-primary lobe. So here, it will not change your T stage.
That was a googly question.
So
One more thing, you can defend of not doing, cannot do a biopsy from a sub-centimeter lesion because all your other lesions are sub-centimeter. Very difficult to go in and take a biopsy even through VATS. Come to your line of management.
So, the plan will be to do carboplatin plus pemetrexed plus minus pembrolizumab based on the patient's affordability.
What molecular testing was done initially?
The PDL one was done, and one could be like EGFR alpha was done.
By what method?
RT-PCR was EGFR was done by RT-PCR and alpha was done by ISC.
And she's a female never smoker.
Yes, sir.
Female never smoker.
Yes, sir. Yes, sir.
So are you tempted to do something else before you put this patient on KN189?
Are you happy with the genetic profiling you have done, or you want to do something more?
We can do FIS for ALK or we can do the NG.
Do you need, if your ALK IHC is negative, do you need to do a FISH for ALK? Yeah, that would be good. I mean, if you have the facilities and obviously resources to get it done, it would be good in this female never smoker stage for lung adeno to get an NGS and rule out a hidden or an occult oncogenic driver alteration sitting there, in which case the pembrolizumab is going to do no good and you'll just end up wasting money. You're asking me or asking me?
Can we please?
Why? Or you want to do both?
What did you say? You are sitting there, you have to tell the, so patient asks, can I get a liquid biopsy done? What will you say? You do it or you don't do it?
You do it.
You will do it. So why would you ask for a liquid biopsy?
Because sometimes if the biopsy is not adequate, then okay, here
Your biopsy is adequate, still the patient wants to do liquid biopsy, your answer is yes, you have to support why yes.
You say no, then why?
So what is the probability of picking up something in liquid biopsy when you do not have extrathoracic metastasis? This patient has had a PET scan and MRI. The disease is confined to the lungs. It is M1A disease, 4A disease. Does the probability of picking up something in liquid biopsy depend upon the stage?
Yes, sir.
What?
Around 60.
That's okay, forget the percentages.
What? Say if there's mets to the liver or mets to the bone, does it make a difference in what you see in liquid biopsy?
So what is liquid biopsy? What are you trying to look at? Correct. So if there is yes, so if there is metastasis in other organs, it implies hematogenous spread. If there is hematogenous spread, the probability of picking up ctDNA is much more than if you have disease confined to the lungs, right? In this case, your tissue is adequate. You do not have extrathoracic metastasis, so your NGS should preferably be done on the tissue and not the blood. Obviously, if the patient is very well to do and says, I don't care, I want to have the highest probability of finding or ruling out an oncogenic driver alteration, then yes, you can do both. But if you have to choose between one, in this case it is tissue NGS and not blood. And what was the PD-L1 value?
20%, sir.
Complete the statement. What you are going to do, how many cycles, what are you going to do next?
So it will be 4 to 6 cycles of pemetrexed for carboplatin, followed by maintenance pemetrexed and last maintenance pembrolizumab.
So this is the only plan you're going to give your patient or anything else?
do response screen.
What will you tell? If your patient asks you what are my treatment options, you will say this is the only treatment option.
No, we can give with the nivolumab options of immunotherapy, nivolumab or single agent we can also offer.
Nivolumab.
When you write orders for the patient, what all did you write when you are planning this therapy?
Prescription.
How do you plan the whole three medications?
Okay. So
Before that, is this the only treatment plan you're going to give or any other combination?
This is a first line therapy. Is there any other option in first line, or this is the only option for the patient? That's what.
If pembrolizumab is your favorite, fine, but do you have any other?
yeah, we can give atezolizumab, bevacizumab, paclitaxel and the carboplatin. We can give gemcitabine, carboplatin with immunotherapy, pembrolizumab.
Is there data on gemcitabine being combined with pembrolizumab? Not to my knowledge. I mean, you have, but that's a Chinese drug, not the ones which we have. So, what would make you use that Pacli, Carbo, Bev or ABCP, whatever you want, over Pemetrexed? I mean, so instead of Keynote 189, you want to use Empower 150 or 130. What is going to be the determining factor which will make you do that?
When do you would use 4 drugs instead of 3 drugs?
Or other question, when would you not want to use Pemetrexed?
Squamous histology.
You already have adeno, right? We are talking
Say
about
when you will not use pembrolizumab and you will use atezolizumab based therapy. See, chemotherapy is fixed, pem carbo is fixed.
No. I am not asking that.
पेमिट्रेक्सेड के कॉन्ट्राइंडिकेशन पूछ रहे हैं कितना क्रिएटिनिन कम होना चाहिए वो सब पूछ रहे हैं
Vijay, one more DM for you.
So obviously, if the patient has a creatinine clearance of 35, there is no question of using PEM, carbo and pembrolizumab. Na? So you will have to go to a paclitaxel based regimen, in which case you can combine atezolizumab or bevacizumab. So that's fine.
What is the creatinine clearance required for to give pemetrexed? क्या कट ऑफ होना चाहिए?
30,
With NSAID, without NSAIDs, अलग है.
50 with NSAID.
Maximum only 45 का लिया हुआ है, पर without NSAID. With NSAID है तो 80 चाहिए होता है. So you have to be very careful while giving NSAIDs on pemetrexed.
So in general, try not to give NSAIDs when you are using potentially nephrotoxic drugs. I mean, you can have tramadol and PCM combinations and codeine and all that. They're probably not worth unless the pain is so severe you have to.
Give the full plan now. You decided on this, give the
What dose of pembrolizumab?
200 milligram, 3 weekly.
So suppose you know about the patient access programs going on, right?
he said this patient
Can afford everything.
So still everybody wants an access.
With pemetrexed, what are the things you look for? What you want to give?
We give vitamin B12 and folate supplementation.
How much? How often?
Vitamin B12 is given every 9 weeks, and folic acid will be given daily. 5 mg daily.
That was the old.
5 mg daily.
That was when I started.
The maximum folate allowed with pemetrexed is 1000 micrograms per day, which is 1 milligrams per day. And so usually 400 micrograms is enough, but let's assume that Indian population is nutritionally depleted. Even then 1000 micrograms. So the typical prescription which I've often seen is full white 5 mg OD should never be given because you're going an anti-folate drug and you are giving 5 milligrams of folate. That is 5000 micrograms. No, it is up to 1000. So what we use is Vitcofol pediatric drops, which has 200 micrograms per ml, and we use 5 ml of that, so that it just goes to exact 1000, not more, not less.
Now there's some regimes giving once in 3 days also. You don't have to. See, you have 20 seconds. Go on, go on. So you have to explain to your patient. Everything. Whatever you can explain to your patient.
So if you're giving an immune checkpoint inhibitor therapy, do you want some additional tests done before you start that?
Yes, sir. We have to do the urine routine examination, thyroid profile, cortisol level, and also
Thyroid and urine is very important, yes.
cortisol and urine routine examination.
And what else you will advise? How will you follow these patients up? If they are on treatment, when will you do this? One thing you didn't comment, MRI brain had no brain exercise. What other things would you look on an MRI brain for such patients in lung cancer?
I will
ठीक है बोले ना क्यों?
That's hard to pick up on.
So what she meant is, you look for parenchyma and look for electrical enhancement. Don't forget it, especially if you turn out to be mutation positive. 5 to 6% good.
And tell one more thing. Suppose this patient was ALK positive. One more thing which is very, very common in that setting. And patients can often come and tell you that I have been having dash for so many days. Very common. For which you will need additional medications to be given separate. No. Like VT is very, very common. In unprovoked VT has a very strong association with ALK positivity.